Next practice. Communication, patient-oriented leadership. Next.
Now we show the flowchart about colorectal cancer patient care. This time we focused on three parts. First, team meeting before the treatment. Second, informed consent for the patient. And third, follow-up during the therapy.
In Japan, standard rectal cancer therapy is first operation. Low anterior resection APR, ISR will be performed, and resected rectum will be analyzed pathologically and decide pathological stage. Next therapy is chemotherapy, chemoradiotherapy, and others. If curative operation was done, there is a possibility of local recurrence 5 to 10%. We must do another chemotherapy or colostomy, and the patient can select dissection. We must perform chemoradiotherapy, radiotherapy, and colostomy. There are big problems. We want to avoid local recurrence and colostomy, and we try to prolong survival because it is necessary.
This is a team oncology. And agenda, I will make a program and why we make a program. And second, how to make a program. And third is what is the program for the program. And last is the next step for our team. So start the presentation.
Now purpose is for colorectal cancer patients, all colorectal patients, and is improvement of cure and care, and next improvement of quality of life. Human and other resources. Team A, medical doctor, nurses, pharmacists, and not only Team A, but also Team B and Team C is very important. Human and other resources. Our team involves a pathologist, medical oncologist, and surgical oncologist, and radiation oncologist. And nurses have many specialties: chemotherapies, ambulatory nurses, oncology nurses, palliative nurses. Pharmacists also many kinds of specialties: drug information, oncology, and palliative. Where is Program? It's medical institute and outpatient and inpatient. Where is support? There is money from insurance, donation, and government. And director of medical doctor, nurse, and pharmacist.
Communication is very important for cancer therapy. We perform various cameras for good communication. For example, through regular conference, morning conference every morning, and case conference, research conference, mortality conference every week, regularly conference, emergency conference, and more educational conference.
This slide shows statistical design of the trial. The estimated gain of pathological response rate, PCR, is 20%. The expected improvement in PCR, 15%. These figures are derived from the previous clinical trial data on neoadjuvant chemotherapy using capecitabine combined with radiotherapy for rectal cancer, and
this is a conclusion slide. This slide shows the QOL and overall survival, and the upper side is better outcome. And this figure shows that patients are supported by Team Oncology. And the initiation of this program, our team is still a little bit small. But after the workshop, we learned a lot of skills of leadership or communication or EBM, and we will go back to each other hospital, and we want to make a big team, and QL and OS will become better. And
they can then work together and identify what the problems are. So it's more of a focus on a whole disease process rather than just we have an assignment to do a protocol and that's what we're going to do, and not have a translation to a bigger feeling of a part of something larger.
See, my concern is we didn't see any build a team. You're assuming there is a colorectal team. There may not be. We didn't see any. We were hoping to see how you're going to put together a colorectal team. I'm a little disappointed, to be honest with you. I didn't see that. And how are you going to go back to your hospital that doesn't have a colorectal team and start one?
They may not have a colorectal team, but the idea of developing a team around whatever it is, whether it's gastric cancer or breast cancer or whatever, I got the sense that this group understood that it's more than just having one doctor who's got an idea, this is what I want to do, and I'm going to write this protocol, and that's it. That in order for them to develop a program, they need a lot of buy-in. They have to go through different levels of the institution to get support. Those things I witnessed in this group. And I think that translation carried through to me. Is that, maybe you guys can speak better to it.
May I have one comment? During this seminar, so we have one of the important key messages is active listening. But in the United States, active listening means to give a chance to talk to the other persons. But there is a cultural difference. In Japan, lots of people have different opinions, but they cannot express their own opinions. So we should extract what they really think. And so maybe yesterday some of the doctors asked to the nurse or pharmacist, what is the question? Is there any question? But they are silent. But we think to extract what they really think. Some good question to be in mind is very important for us. And, maybe from today, they will make a good team and to expand, to recruit Group B or Group C. But at the time, please make efforts to extract what the patient really think or their real goal for treatment.